We'll start questions now. I will start taking questions. There are several questions. I have questions to the audience. Now I'm going to pick on pick 5 of the audience here from different parts of the world to ask them if they already do contrast enhanced ultrasound or not. So I would, some of the permanent attendees here, Arwa Badib from Saudi Arabia. Do you guys do contrast enhanced ultrasound now? Arwa?
Hi, good evening or good afternoon. How are you guys?
Good.
No, we don't. We don't use contrast enhanced ultrasound yet.
Is it
Pediatric,
only in your institution, only in your institution, or in your country in general?
I cannot speak about the whole country in general, but when I came to King Abdulaziz University, we didn't have contrast enhanced ultrasound as a modality. We have a couple of the pediatric radiologists who are very keen to bring in the contrast, but overall, in general, we heavily rely on CT and MR.
Oh, okay.
Especially with the adults.
Okay.
Yeah. When I trained back in the US, the training center that I joined, they didn't believe that much in contrast enhanced ultrasound, so I didn't have even the advantage of training on contrast enhanced ultrasound myself. So I feel myself lagging behind when it comes to contrast enhanced. So I have a lot to learn about it before, if we want to start doing so for these cases.
Okay, a second one, Daniela Sigura. Daniela, I'm bringing you on the spot here. There is another Daniela Parenti. Too. Think you guys from Brazil? Okay. Okay, Daniela. Now you're on.
Hi, Doctor.
Hi.
Hi, Dr. Elsayes.
Hi, how are you? So
thank you for the introduction.
So where are you from?
We don't have many. I am from Rio de Janeiro.
Rio de Janeiro, yeah. So do you do contrast enhanced ultrasound?
No. Sorry, I don't have any experience.
So what about,
I think it's very interesting.
That's all in Brazil, or do you think there are some institutions in Brazil that do it?
No, we are beginning. We are gaining experience, but it's not widespread.
Oh, okay. All right. So okay, great. What about Pradnya Mahtar from India?
Well, I'm not from India. Well, I'm from India, but I'm sitting here in Virginia.
Oh, okay. I thought you're from...
Well, I am from India.
Oh, okay.
But I've been in the US for 25 years.
Oh,
so,
okay. Should I pick another one from India? Raj, I think Raj Hilavar. Raj, do you guys do it?
Hi, Dr. Elsayes.
Hi, how are you?
We don't do it in our institution. Hi. We don't do it in our institution, but there are multiple other institutions doing. A few of them are definitely doing huge volumes with liver transplantation and HCC programs. We don't do it in our institution.
Okay. So Roberto Canella from Italy, I think Europe is even before us with that. Roberto, we have 3 from Italy, by the way. I discovered that we have Giorgio also from Italy. So Roberto, buonasera, sir.
Buonasera. Yes, she's one of our residents.
So you guys do it, right?
Yes, we do it quite a lot for
yeah.
problem solving, and actually we do a lot for the post-treatment response where MR is not really clear if there is real enhancement or not.
Okay, you guys are before us in doing that. Last one is Dr. Eid from Egypt. Do you guys, Mohammed, do you guys do it?
No, we don't have an experience in contrast ultrasound in Egypt.
Not even University of Cairo?
I'm not quite sure about Cairo, but here in Alexandria we don't do it.
Okay, all right, great. So David, I just tried to give you some.
Dr. Khaled?
Yes.
Dr. Khaled?
Yes.
I had my residency in Qasr Al Aini. my master and MD.
Well, so who's speaking now? Sana? Is it Sana or who?
Sana.
Yes.
Sana.
Okay.
Yes.
Okay. So you do it?
It is not used in the radiology department, but I have knowledge that it was used in the hepatology department because they have their ultrasound unit.
Yes. That's the case.
And it is yes, it may be used also in hepatology institute in Egypt, in Cairo.
Okay.
But not in the radiology departments.
Oh, okay.
It's,
All right.
it's a hepatology.
Sana is saying one of the comments here, David, this lecture made me love ultrasound. So, and she's saying fantastic lecture. That's her comment before me asking this.
Okay.
Do you guys have any question? I don't see any question. I see just compliments and good comments and compliments to the lecture. Is there any question from the audience here? No questions from the audience so far. Dr. Serlin or Victoria, you guys have any questions? I think, David, part of this is that no one has your expertise with contrast-enhanced ultrasound. So I think everybody is delighted and really happy with the lecture. But yeah, but Roberto has a question. Roberto, go ahead. Roberto.
Yes, thank you. So growth is right now an ancillary feature for the contrast-enhanced ultrasound. Can we apply that button on cross-sectional imaging? Because usually we perform contrast-enhanced ultrasound just once at a time and not for real follow-up.
So I didn't quite hear your question that well. So you were asking if we use this as a screening tool or for follow-up?
No, if we can use the growth based on the CT and MRE growth, or we should apply only when we use contrast-enhanced ultrasound, so during the follow-up with contrast-enhanced ultrasound.
So I don't know of any studies that have compared size of observations between modalities, so how it's measured on MRI or CT, and then how it's measured on ultrasound. So if something is first seen on CT, MRI, and then you do a follow-up with contrast-enhanced ultrasound, I think the benefit there would be to see if there's any differences in the enhancement characteristics. For instance, you didn't see arterial phase hyperenhancement on CT or MRI, but you do a follow-up with ultrasound and you identify that critical arterial phase hyperenhancement. Or similarly, you didn't see washout before and then you're able to see it on contrast-enhanced ultrasound. I think that's a huge benefit. If you're following a lesion observation over time to see if it changes in size, I think you need a baseline contrast-enhanced ultrasound and then follow it thereafter with that same modality. You know, we have some hepatologists who like to bounce around with different modalities to follow up size of observations, and we're having a hard time telling them, no, if you're just following on size, stick with the same modality, because we're wary about comparing sizes between modalities. So I hope that answers your question.
Yes, thank you.
Tana, do you have a
hey David, this is
you have a question, Tana? Who's talking now? Is it Claude or who?
Oh, this is Claude. I have a question, but I can wait. If someone else has a question, I can wait.
Yes. Thank you for being fearless leader and waiting for your colleagues. Tana, you can ask if you want.
Assalamu alaikum. That is, to me, if we had an observation with ultrasound that is clearly categorized according to ultrasound LI-RADS, would we treat this observation, or we should do another modality like CT and MRI? Is contrast-enhanced LI-RADS enough?
And that's a really good question. I think what you're alluding to is like the downstream management. For instance, if you call an LR4 or LR5 observation on contrast-enhanced ultrasound LI-RADS, you can still for LR5, say that that patient definitively has HCC, and you can initiate treatment. So for instance, we've had some patients, like that last case I showed, where we did not go on to a staging CT or MRI for various reasons, and just locally treated that observation based solely on the ultrasound and contrast enhanced ultrasound features. Now, if that patient needs complete staging for other reasons, transplant evaluation, for instance, then I would think that most places would send that patient then to a staging modality, so CT or MRI. I think the benefit of contrast enhanced ultrasound is not necessarily to be the definitive diagnostic test in every case, but to expedite workup in identified observations seen at a screening or surveillance ultrasound, or to be a troubleshooting tool when there's an issue with a CT or MRI examination. But if you do see an observation LR5 on contrast enhanced ultrasound that is definitive for HCC, and so you can initiate downstream management based on that, based on the literature showing that we're 98% specific for HCC in that category. So I think it carries the same diagnostic information, but the decision about whether or not to go on to a staging CT or MRI is probably going to be patient specific.
Thanks a lot.
Great, thank you very much. Claude, would you like to give the question?
Yes, thank you, Khaled. Before I give the question, though, the last question has triggered a research idea, which I'd like to share with the audience. I sometimes like to share research ideas. Until now, no one has been excited by any of my research ideas, so maybe this one will be just as bad as all my others. But if anyone is interested, I think this is potentially an interesting question. So if you have an ultrasound for screening or surveillance and it shows a nodule, it seems to me that one obvious advantage of doing an immediate contrast enhanced ultrasound is if you can actually show that that nodule is not a LI-RADS 5. So if that nodule in fact is a LI-RADS 3 or a LI-RADS 2, then you will have achieved something very important, because you'll be able to tell the patient, I found the nodule on the screening ultrasound, but good news, it doesn't look like a cancer, and we don't need to do anything right now other than to have you come back in 3 to 6 months for another ultrasound. So I think that's an obvious advantage, and it'd be an interesting research idea to find out how much that benefits the patient in terms of a reduction in anxiety, a reduction in cost, et cetera, et cetera. The next one is, you do an ultrasound and you confirm that it is an HCC. Now, what would be the benefit of that? Well, at UCSD, it's a little bit different maybe than at UT Southwestern. At UCSD, we would almost always do a staging CT or a staging MRI before treatment, because we'd need to know what else is in the liver. We wouldn't want to treat a 2 centimeter or 1.5 centimeter HCC without knowing what else is going on. However, a hypothesis might be that for patients, there's actually quite a bit of advantage in proving that it's an HCC, even if they're going to need a staging study, because you let them know earlier what it is, so there may be a little bit less anxiety about not knowing what it is. And a hypothesis might be that it would accelerate the time to treatment, because if it's just a positive ultrasound and you're waiting for the patient to come back, I'm hypothesizing that that pathway is longer than if you say this is definitely an HCC, and then the treatment and the whole workup can happen faster. Let me pause here for a second. I still have a question, but before I say anything else, David, what are your thoughts about any of this? Does any of this seem resonate with you, or do you have any experience about some of these issues?
It resonates with me greatly, and I think more so resonates with our hepatologists. So after we started talking about the utility of contrast enhanced ultrasound in our workflow, they became incredibly excited about both the paradigms you talked about if we do identify something on a screening or surveillance ultrasound and we can show that it's not suspicious for HCC, then they don't have to rush that patient back in the clinic. They don't have to go on to a CT or MRI. They just return, either to routine surveillance or maybe a 3-month follow-up. and you're not, raising the anxiety level of the patient and utilizing precious resources. So I think that is a great benefit that we are tapping into here. The other benefit you alluded to is expediting management. So we actually have many, many, many more at-risk patients in the DFW, Dallas-Fort Worth area than can be handled by our HCC clinic. So our cirrhotics and our other high-risk patients may be managed by family practice, internal medicine, the non-HCC GI group, and so forth. And so only those patients that have a suspicious observation are actually being managed and followed by the HCC subgroup. And so if we can help them triage and get those patients into the HCC clinic faster by characterizing an observation identified on screening or surveillance ultrasound as suspicious for HCC, in our system, it dramatically accelerates getting them plugged into the appropriate clinic and then accelerating definitive management. So I know everyone's practice is a little different, but those are the direct benefits that we're beginning to see at our institution.
So, Claude, can I say something that could be related to that before getting to your question?
Of course.
So David, I even asked you about that the other day, and I think you addressed it the other lecture and right now also, which is characterizing the observation that you see on surveillance on the spot by contrast-enhanced ultrasound. That would be really, I think, nice. But the other thing is, has it been investigated the utility of contrast-enhanced ultrasound in characterization compared to contrast-enhanced CT or MRI? Meaning that, I think it will be very advantageous to do contrast-enhanced ultrasound on the spot for patients on surveillance with positive observations, right? But let's say that you did the observation, you did the surveillance ultrasound, there was observation, patient went away home, and patient will need to come back. Would it be better to do contrast-enhanced CT or MRI or contrast-enhanced ultrasound? Has this been investigated elsewhere? Or what do you think about this as a potential also research question?
Are you talking about a workflow benefit or a diagnostic performance difference between modalities?
Well, the workflow benefit, I know that it will be to the advantage of ultrasound, right? But I'm asking, and also a cost-benefit effectiveness will be also in the favor of ultrasound, I believe. But I'm asking about the diagnostic utility now.
Yeah. So I will tell you that the multi-site trial ongoing based out of Jefferson with Andre Lishik is collecting that data. So for every subject we're recruiting, they will have a multi-phase diagnostic quality CT or MRI within a short time frame of that contrast-enhanced ultrasound. So we're intending on doing a multi-reader study on all those diagnostic studies. So we will have that head-to-head data in that population in the years to come.
Okay. Claude, you can ask your question, but I have also a question from Daniela Parenti from, I think, Brazil, but go ahead and ask your question first, Claude.
No. Well, yes, no, please ask Danielle, please. You're more important. Go first.
Daniela.
Hi, thank you. So I would like to know, how should we select the patients to undergo contrast-enhanced ultrasound after being positive for a LI-RADS 3 or a LI-RADS 4 on CT or MRI? We have a lot of patients with LI-RADS 3 and 4. So which one should I choose to undergo contrast-enhanced ultrasound?
I think, obviously, I don't think any ultrasound department is going to have the bandwidth to do a follow-up contrast-enhanced ultrasound for every LR3 and LR4 observation we're seeing on CT or MRI across your entire enterprise. I think it should be patient-specific, and if the additional information you will glean from the contrast-enhanced ultrasound will change management. So I can, imagine if you're trying to get exception points for a potential transplant patient, for instance, or you're trying to decide between different treatment modalities. And so a lot of our follow-up of contrast-enhanced ultrasound following a CT MRI comes out of multidisciplinary conferences. So our weekly HCC conference, obviously we're presenting our most difficult patients or patients that need a management discussion, and a handful of those will say, hey, would contrast-enhanced ultrasound added to this, if we're able to show residual disease or able to show arterial phase hyperenhancement in this observation, would that give you additional information that would change management? And in a fraction of those, they'll say yes. And so right now, most of our follow-ups are coming out of a multidisciplinary conversation.
Great.
Thank you.
Thank you.
And do contrast-enhanced ultrasound give exceptional points for liver transplantation?
Yeah, that's an unfortunate no. So at least United States, UNOS does not use contrast-enhanced ultrasound information for exception points. So that's something that we're trying to collect the data for and trying to advocate for, but currently no. So that is one drawback. But contrast-enhanced ultrasound continues to advance in the literature supporting its use. And the data that's supporting the LI-RADS system. And so much like how the latest version of AASLD now includes contrast-enhanced ultrasound as a diagnostic modality, we're hoping that the transplant community will follow. So not currently, but hopefully to come.
Dr. Serlin.
Thank you. Thank you.
Thank you very much, Daniela. Dr. Serlin.
Yeah, David, I was wondering if you could comment a little bit more on the time frame of arterial phase hyperenhancement. How fast does it happen? How fast do you see rim enhancement, for example, with a cholangio? Do HCCs ever show rim enhancement for half a second or a second before they fill in? What is your experience on those critical couple of seconds when the enhancement is first beginning in the arterial phase?
Mm-hmm. Yeah, I think that's one of the interesting things, and probably one of the benefits of contrast-enhanced ultrasound is that on the patient level, arterial phase is quite variable. So if I have a young gentleman who has great cardiopulmonary status, we may see bubbles in his liver less than 10 seconds after injection. Whereas if we have a patient with heart failure and is 350 pounds, we may not see contrast in the arteries of the liver for 40, 45 seconds. And I think that speaks to how variable we see it on CT MRI, and how sometimes we have, quote, mistimed arterial phase, either early or late, because it's so patient to patient variable. The benefit of ultrasound is that we're watching continuously, and so we can start acquiring our, quote, arterial phase cine loop as soon as we start to see bubbles, and then acquire a 30 to 60 second loop after that. And so we very rarely have to worry about missing the arterial phase. And to the second part of your question about pattern of enhancement, what is fascinating, and I don't think anyone has looked at it to great detail, is that since we're running at 9, 12, 15 hertz, we're able to see second and even microsecond changes in the enhancement pattern, and it is quite interesting how fast that appearance changes just frame to frame. And so, as I think you alluded to in your follow-up question to a recent lecture, is that some cholangiocarcinomas on contrast-enhanced ultrasound are markedly hyperenhancing, but only for a fraction of a second. So it's just a couple of frames in that long cine loop. So I have to say that for all the cholangiocarcinomas that I've seen have a markedly hypervascular, irregular rim, that may not have been seen on CT MRI, and I don't know if it's a function of the differences in the contrast agent, in the differences in the timing, or both. I don't know. Well, I mean, we'll have to probably go back and look at our data with Andre on how many times a rim enhancing pattern that would be characterized as an LRM goes on to be an HCC. But again, we're collecting that data, so that's something that we can definitely look at and see how often on contrast enhanced ultrasound and HCC, and true HCC shows rim enhancement.
Okay, great. Thank you very much. Thank you, David. And David, can I ask you a favor before I end the lecture here?
Of course.
Can I ask you to be like for your kindness and to slow down your research, because we still want to maintain our business as CT and MR leaders for reading advanced imaging for the liver. Otherwise, we'll not be able to, earn our make our daily living. We want to feed our kids. Keep feeding our kids, my friend.
Well, I appreciate it. The ultrasound community is small, so those of us in it have to just bark a little louder.
You take your time. Take your time, David. No rush. Take your time. Okay, we have some people here who lose their business if you guys are going to replace them. Otherwise, we'll need to learn contrast enhanced ultrasound and start doing it. So thank you very much. Thanks, David, a lot. We really appreciate that. That was one of the best lectures, if not the best lecture in the whole series, because it was really cutting edge. It was something that you are experiencing, and you build expertise, and you really became the go-to guy for internationally for contrast enhanced ultrasound. So we really appreciate that. Appreciate your lecture. Appreciate your time. And I also thank all of our colleagues here who attended the lecture. I thank Claude and Victoria for always being around here to help us in this series. And I thank our colleagues from over the world who provided an insight about the use of contrast enhanced ultrasound in different continents. With that, I will conclude the session. I thank you all very much for that, and I wish you, a very happy and nice weekend. By the way, tomorrow there is a webinar that I'm doing that is outside the liver series. It's a COVID-19 webinar. I have like some colleagues, radiologists, Dr. Bashir Taouli, and Keith is an infectious disease specialist, and Nicole is a virologist. And there is a lot of interesting questions to them. If you would wanted to attend, let me know. I am happy to send you, even if you didn't register till now. There are only a few slots left. You guys have a nice weekend. Thank you very much.
Yes, thank you for organizing. I really do appreciate it. I don't think anybody else could have put this together as quickly or as efficiently as you. So we all appreciate everything you've done.
Thank you very much, David. Thank you very much for giving the time and efforts to do this also and to contribute. I appreciate it.